Hi everyone, my name is John Kirago. I would like to present to you a quality improvement project, a short story about the project. Um, this is a quality improvement project that aimed to improve quality of maternal health care in a peri-urban health center in Nairobi, Kenya. So just a bit of a background. Uh, Poor maternal health outcomes such as very high maternal mortality ratio as well as neonatal mortality ratio have been attributed to poor quality of maternal health care. For example, maternal mortality ratio of Kenya is 5 times more than the sustainable development goal of having less than 70 maternal deaths per 100,000 live births. Similarly, neonatal deaths are twice higher than 12 neonatal deaths per 1,000 live births as per the SDGs. So these grim statistics have been attributed to poor quality of maternal health care. For example, the Kenya Demographic Health Survey just recently showed that only 60% of babies in Kenya are put to their mother's breasts within 1 hour of birth. Uh, so exclusive breastfeeding is suboptimal, skin to skin care is suboptimal. So this quality improvement project had the aim of improving adoption of um, three evidence-based techniques of midwifery care. And these are, as you can see here, these are the skin to skin care, evidence-based, delayed cord clamping, evidence-based, and dynamic positions of birth. All these techniques are evidence-based. So we sought to improve adoption on the same, and that was the main aim. Literature has shown that these techniques can improve maternal health outcomes. For example, dynamic positions of birth, they've been shown to shorten the second stage of labor. They have been shown to reduce incidence of perineal tears and operative deliveries. Delayed cord clamping has been shown to reduce instances of neonatal anemia. Skin to skin care and has been shown to support early breastfeeding, reduce crying, improve mother-baby interaction. So these techniques have been recommended by the WHO. But the question is, what is the rate of the adoption within our setup? So within the selected health facility in Nairobi, Kenya, Kayola Health Center, adoption for these practices was poor, as shown in this graph here. So at baseline, dynamic birth positions were at 0. At baseline, the correct technique of skin to skin care was 0. For delayed cord clamping, the baseline was 80%. However, the practice was not uniform among the midwives. There were still some misconceptions and false beliefs that delayed cord clamping increases the risk of HIV transmission among the neonates from seroreactive mothers. So we had to go back to literature and come up with an educational intervention that is evidence-based and train and impart that knowledge to the midwives, to the facility midwives. And that was part of the first aim of the implementation. And the second aim, like I said, was to estimate the costs of implementing or improving adoption of these practices. So the implementation followed the PDSA cycle according to Lagle 209. The PDSA cycle is a cycle where you plan, do, study, and act. So as you can see here, we have planning phase, where the implementation phase, and then we have the part where we studied the results and even acted on the results. So in summary, the planning phase involved building capacity for midwifery leadership. Building capacity for midwifery leadership. Then after planning and getting necessary approvals from the county, we implemented the educational intervention on the three techniques. After implementation on the same, we evaluated the baseline as well as the level of practice after the 11 weeks of implementation. Then lastly, we studied the results. We communicated the findings to the facility midwives. We had workshops just to be able to discuss some of the findings, some of the implementation challenges, and also to validate some of our findings. Yeah. And then lastly, according to the model, we acted on our results. Acting, we reviewed literature to link the outcomes to potential impact on maternal health care. For example, literature shows that adoption of dynamic positions of birth can reduce complications, operative complications such as cesarean deliveries. So that was discussed, and we thought our findings were very, very important, and the facility agreed, to sustain and to look for means for strategies to sustain this kind of quality improvement work. As per our second, okay, before I go to the second aim, results for the second aim. So from the first aim, we had adoption for dynamic birth positions, 36% adoption for the dynamic birth positions, and 79% adoption for the correct practice of skin-to-skin care. For delayed cord clamping, adoption was minimal. We actually didn't have any change from the baseline of 80. So we recommended the facility to explore ways in which the practice of delayed cord clamping, based on the knowledge that we shared. We recommended the facility to explore barriers to optimal adoption of delayed cord clamping across all the babies and all the mothers, whereby this practice is indicated. Lastly, as per the second aim, we observed that under a collaborative implementation strategy, which was, how these projects were implemented, the facility incurred very reasonable costs, financial and economic costs. However, if the facility was to implement this project without any donor support or any aid, the facility will need to have much more budgetary allocation, much more money than the facility is currently having to be able to scale up or to sustain implementation of this project. So information on cost was important for the budget holders who may be interested in feasibility of a quality improvement project such as this. So this is a short story about what we did. I look forward to interacting with you. Your comments are welcome. Thank you very much. And before I finish, this work has since been published. It's out there under Elsevier, Sexual and Reproductive Health, Healthcare Journal. Thank you very much.